Dr. Marilla, do you have something to say about it?
I mean, I can start off definitely. Sorry, Dina, I thought you might have wanted to say something. So first of all, I think we already have overconsumption of antibiotics in general in the world. I think the less we use, the better, because we have, developing complete resistance to antibiotics. So I don't think that's really a good way forward. And I think it was clear from my presentation and Dr. Susu's as well that actually giving antibiotics topically or orally isn't working terribly well, especially for these really deep wounds, because it cannot penetrate. And I guess when it's not penetrating, you're giving it as an oral antibiotic. But I think, like we've said several times, prevention is better than dealing with the consequences. That's why I use the examples of just a couple of trusts that actually had been kind of monitoring people's feet as part of routine preventative measures. So calling in patients every 3 to 6 months just to monitor their feet, just like we do retinopathy. When we think about how much diabetic retinopathy screening has actually changed the lives of diabetics. So that's kind of changed in the UK, I think from the 1980s, when it's become a routine that once a year you go to your diabetic retinopathy. We have had a massive change in number of blindness, complications like glaucoma, cataract, etc., in people living with diabetes. In the same way, we should kind of take the diabetic foot ulcers a lot more seriously. I think Dr. Susu showed a really nice example from the New England Journal of Medicine paper, which showed for 3 years there was an ulcer there, sitting there untreated. And of course, if you leave something there, it is going to grow into a big problem. So actually having 6 monthly checkups as a part of your routine checkup, as you would be seeing your nurse, diabetic nurse or diabetic clinician, is probably the best way forward. But I certainly wouldn't be recommending giving people antibiotics, considering that we don't have antibiotics to deal with much worse infections when we go into hospitals. So that would be my answer.
Thank you. I'd also would like to add, if there is an active infection that requires parenteral antibiotics, it has to be treated with antibiotics. Otherwise, it will grow much faster. So even if it's a polymicrobial infection and we need to have a very good stewardship use for antibiotics, however, we still need to treat active infections. But to use antibiotics as prophylaxis for inactive ulcer, I don't think it's recommended, as Dr. Marella said. It is the topical antibiotics, again, may not work for deep ulcers, only for superficial ulcers. We will continue the discussion after Ms. Dina finishes her talk, but
okay.
keep asking. We have one more question after you finish from another attendee. So go ahead, Ms. Dina.
Okay, thank you so much. So going back to the economic of diabetes, so we can classify the cost to direct or indirect cost. Direct costs, these are the costs that directly related to the healthcare system or to the medical conditions of the patients. An example of these cost of medications we use to treat diabetes, or medications we use to treat comorbidities or complications because of diabetes. Cost of services patients received in the outpatient visit or emergency visit, cost of hospitalization, and sometimes some patients may receive additional or home health care, especially the geriatric patients. While indirect cost, now because of the dynamic diabetes, it's a dynamic disease, and it causes complications. Some patients may take some days off from their work, and some patients may lose productivity in their work. So we need to think about all these costs as well, not just the costs that are related to the healthcare system. So examples of these, like the cost of absence from work because of diabetes, or cost of lost in productivity because of diabetes, and the premature mortality cost as well. Now, less evidence has been generated in relation to the economic impact of diabetes complications, and what are the major contributors or the major drivers of economic burden of diabetes complications. Now, why it's important for the patient or the clinician or policymaker or researcher to understand the economic burden of diabetes complications. For example, for the patient and clinician, it's important to understand the value, why it's important to delay, to prevent, or at least to delay the incidence of complications. And for the policymakers or researchers, for example, they can help in in understanding the tools sorry, that can be used to for preventive measures, for example, or how to allocate the resources more efficiently. Now, let's take a closer look of this. This is a great comprehensive article published by the American Diabetes Association about the economic cost of the diabetes in U.S. population in 2011. They looked at all the types of costs, direct and indirect costs. So I'll start with the direct cost. So here, in terms of the health resource use, around 162 hospital inpatient days spent by U.S. population in 162 million hospital inpatient days spent by U.S. population in 2017. Of these, around 24.8% of these days were just incurred by people with diabetes, and around 13.9%, which is equivalent to 22.6 million hospital inpatient days, were just related or directly related to diabetes. Also, half of the physician office visits, emergency visits, services received during the outpatient visits, medication prescriptions that were incurred by people with diabetes were just related to diabetes. Now, with regards to the healthcare expenditure, around 1.6 or 1.7 million US dollar was just spent on the US population in 2017, and around 24% were just incurred by people with diabetes, and 14% were just attributed to diabetes, which was equivalent to around 237,000 US dollar. And the major contributors of the huge health expenditure on diabetes were because of the services the patient received during their hospitalization, the services that the patients received during their follow-up with the physician, or the prescription medications. Now, the majority of these expenditures, or around 61% of these were in patients above 65 years, which was equivalent to around 15,000 US dollar per person as an average cost, which was around double than those who were less than 65 years. Now, with regards to the medical condition-specific expenditures that are associated with diabetes, for example, patients who have diabetes and peripheral vascular disease, around 39% of care received because of peripheral vascular disease, or in patients with peripheral vascular disease, 39% of these expenditures were just related to diabetes. And similarly to patients with neurological problems, 36% of the expenditures were just related to diabetes. Now, what about the indirect cost? Now, it's always important to think of both the direct and indirect cost, because some people may just skip the indirect cost and think that the diabetes, or let's say any chronic condition or any disease, just affect the healthcare system, but it's not affect the individual and the whole society. For example, here, around 89.9 billion US dollar was just spent on diabetes in US population 2017 as an indirect cost. Imagine something not related to the healthcare system, just something related to the government, to the individual. So the majority of these were because of reduced labor force participation because of disability, because of diabetes, and it cost around 37.5 billion US dollar, which was equivalent to around 182 million days lost because of diabetes. This was followed by reduced performance at work, and it cost around 26.9 billion US dollar, which was equivalent to around 114 million days lost at work because of diabetes and because of diabetes complications. Now, premature mortality is another important event that we need to pay attention to as well, because not all the researchers or not all the decision makers think about the premature mortality. Around 19.9 billion US dollar was contributed to mortality cost because of diabetes, which was equivalent to around 277,000 death cases. Now, in patients, for example, with diabetes who died because of the primary cause was diabetes, this was an 85,000 death case. While, for example, in patients who died because the primary reason was cardiovascular disease, and those patients, for example, around 111,000 death cases were just related to diabetes. Now, what is happening here in Qatar and how it's different from the international trends? So this is another great paper published by done by local researchers in Qatar about the economic burden of diabetes, and they included adult patients with diabetes and visited the Hamad General Hospital and Primary Healthcare Center over a 10 years period from 2004 to 2014. So here they classified the average annual diabetes treatment cost based on specific categories. For example, based on the socio-demographic characteristics, the left-sided table, the patients who visited the primary healthcare center and the hospital, the average cost was almost similar between the two settings, which cost around 3,300 US dollar annually and per person. And it was highest in the age group between 31 to 45 and more in male patients compared to female patients. And of course, patients who visited the setting more than 7 times a year, they cost the most. With they classify the annual treatment cost also by patient clinical characteristics, and they found also obese patient cost the most, and it cost around 3,228 US dollar per person. And this is another paper that emphasized on obesity here in Qatar and its important risk factor of diabetes. And of course, patients who receive insulin plus oral medications, and especially the basal kinds of insulin, these are very expensive. And of course, patients who have longer duration of diabetes and patients who had more than 3 times hospitalization because of diabetes. Now, with regards to the annual treatment costs by diabetes complications, they found that around 3,695 US dollar was it cost the patient because of diabetes-related complications, and the majority of the major factors were because they spent more resources on regulating the blood pressure, nephropathy, liver damage, and high cholesterol, and all costs are contributed to a similar amount. Here they did the great regression analysis to find the relationship between the cost of diabetes in Qatar and some factors, and they found that the economic cost of type 2 diabetes increased with increasing the age, with having dyslipidemia, cardiovascular, cerebrovascular disease, foot-leg ulcer, use of insulin, and of course with the longer duration of the disease. Now, because again, diabetes is a dynamic disease. So again, some patients may take some time off from their work. Some patients, unfortunately, lose their work because of the severity of complications. And Some patients may just lose their insurance because when they lose their job. So this is a great report published by the US based on prescription claims from 2016 to 2017. They looked at the true cost of diabetes and they classified into controlled diabetes and uncontrolled diabetes. Here, when we talk about the controlled diabetes, we assume that the patient have stable blood sugar and they just manage the risk of having complications. So they found that the patients without insurance paid more on medication, hospitalization, outpatient visits, of course, compared to patients who have insurance. Now, while patients who have controlled diabetes can be expensive, imagine patients who have uncontrolled diabetes. This can be even more expensive, and especially those who pay, who spend money as an out of pocket. So, for example, yes.
5 minutes.
Okay. So, Okay, so around some patients, because of the uncontrolled diabetes, they spend around $125 in the emergency visits, and some patients, because they required additional home healthcare service, they paid additional $572 as out of pocket. I'll just skip this slide and just emphasize on this again that diabetes is a social burden. It's not about the only the direct costs and the tangible indirect costs. Unfortunately, some people may also have pain and depression because of diabetes, and some people, or the majority of people, just ignore the cost of treating such comorbidities because of diabetes. And for example, in a paper published done in US, they found that cost of treating depression in diabetes patients increased by around $5,170 US dollar per person compared to those without depression. Also, we need to think about the diagnosis and to avoid delayed diagnosis because it also have a huge burden on the country. Now, what can we do to curb the progression of diabetes complications or the economic burden of diabetes? We can simply prevent the diabetes, and Qatar is doing very well in this. This is part of Qatar National Diabetes Strategy. They have started screening all high-risk population, and they have started offering healthcare plan. We can decrease the risk factors for complications. For example, we can use the results of STEAM or advanced trials. We can use GLP-1RA agonists or sodium glucose inhibitors. These are new medications, anti-diabetic medications, and have been shown to reduce cardiovascular and chronic kidney disease, especially in high-risk population or high-risk diabetes patients, and are cost-effective. PCSK9 inhibitors are very promising medications. They have been shown to reduce cardiovascular disease and mortality in diabetes patients. But the problem is with their cost. They are very expensive. You cannot imagine how much it costs to receive single injection from this medication. Therefore, their cost effectiveness still has not been widely, still it's debatable. So all the solutions that I have mentioned here requires behavioral change, and the whole healthcare system requires behavioral change. This is the case discussion. I'm not sure if I have time to go
Actually, we only have 5 minutes left of the session, and we have one question to be answered by the audience, and if they have more questions, but then you probably should go ahead and discuss the case, but first let's answer the question that's pending here. The question is, what do you think of treatment of dyslipidemia and hyperuricemia aggressively? Will that prevent diabetic foot ulcer? So, Dr. Myrella, would you like to answer that? Treating hyperuricemia and dyslipidemia, would that prevent diabetic foot ulcer?
I guess treating the hyperdyslipidemia, first of all, would be really beneficial to protect against cardiovascular disease. I think this is why the patients are, well, in UK, they are very well monitored for changes in lipids and hypertension, really, in order to decrease that risk of dying of cardiovascular disease. So to answer your question, you know, I guess down the line, it may improve outcomes in diabetic foot ulcers, but to be quite honest, I guess the bigger problem there, if somebody has got hyperdyslipidemia and uremia, is that they're much more likely to develop they have problems with cardiovascular disease and liver problems. And then again, you know, when you talk about the treatments, it takes us back to the diets we talked about. I think nutritional approaches would be really kind of beneficial for those patients with gout, because it has been shown that diets that are rich in protein, animal-based proteins, can make gout much worse, and fruit and vegetables, fresh fruit and vegetables, that improve it. So by itself, I guess DFU may improve, but it wouldn't be a major concern. That's my personal opinion, that you're actually treating a much bigger killer, which is the CVDs.
Yes, thank you so much. And also, reducing the level of uric acid is important because the hyperuricemia state is inflammatory state as well. And that may not help the immune system to revive and help with the wound healing, and that also facilitate diabetic foot ulcers. Let's see in the last 3 minutes if Ms. Dina could discuss the case with the audience quickly. Go ahead, Ms. Dina.
Okay, thank you so much, Dr. Suso. So we have here the case. We have a patient is 67-year-old man, 75 kg, with type 2 diabetes. He takes metformin, 1 gram BID. He has no other chronic diseases or history of cardiovascular disease. His recent vital signs and lab tests are blood pressure 159/93, heart rate 71 BPM, A1C 6.9%. Which of the following options, if we added to metformin, the standard care, has the most potential to reduce both micro and macrovascular complications in that patient, and of course improve his quality of life, and eventually you will have reduction in his overall management costs. So is it insulin glargine, lisinopril, glyburide, or niacin?
Type answers, please.
Yeah, and if you can just type a short justification why, for example, you are picking A or B. Okay, so I can see the majority are selecting B. Yeah, and justification for the B. Okay, so just because we are running out of time, so yes, you are right. B, lisinopril is the correct medication because, yes, great, yes, because of the hypertension, and hypertension is a major comorbidity of diabetes, and the patient is having high blood pressure, and it should be within the target less than 140/90. And hypertension, if we control blood pressure, we can control both micro and macrovascular complications. The other options wouldn't have a huge impact on the macrovascular complications, and niacin have not shown reduction in both micro and macrovascular complications in diabetic patients, especially as a solo anti-dyslipidemia medication. Now,
all right.
Okay. Okay.
Yeah, I think we ran out of time. Thank you so much, Dr. Dina, for a very informative session. But we have a very important and crucial question that I just saw here. The question is related to how can we manage diabetic foot ulcer during COVID-19 lockdown? And what advice to the diabetic patient to seek medical emergency at this stage? In fact, this is very important because we're right in the middle of the second wave of COVID-19, and the new variants are spreading quite faster. So the health services, at least in the case of Qatar, only for emergency and COVID being channeled so far. But if diabetic foot patient has an emergency situation, all emergency rooms are open, You could call your doctor over phone consultation. You could go to the emergency room and get the treatment if you do not have it already at your disposal. But definitely be very cautious with the precautions to prevent infection, like your mask must be on all the time, even if you are vaccinated. No one should let their guards down right now, even if you are vaccinated, because the spread of infection is going and soaring, and vaccinated people may capture the infection without feeling it and become carriers. So to protect yourself and others, please, please, everyone, your mask has to be on all the time. And with that, I think if you have something to add, go ahead.
Yeah, if I may, I don't know if you do video consultations, but that's the case very often here now, that there's a lot more video consultations with your primary care physician, etc. And also I know from all my colleagues who are cardiologists, they're begging people to go for their checkups. So that could be video, it doesn't need to be in person, but basically people are leaving it too late, not seeing their doctors and nurses. Therefore, by the time they get to ICU, it's too late. They don't want them to be getting to ICU. They want them to actually prevent rather than deteriorate.
Excellent. Thank you very much. Any last burning question from the audience before we thank you all and say goodbye? All right, it's been a pleasure having Professor Myrella with us. It's been a pleasure having Miss Dina with us. Thank you, Sahar, for all your help and coordination. And thank you, audience, for attending this session. I would say good night to all of you. Enjoy the rest of the evening if you are in Qatar, and if you are somewhere else, enjoy the rest of your day. Have a good night, everyone. Bye.
Thank you so much. Thank you.
You're welcome. You're welcome. It's been a great session. Thank you.
Thank you.
Bye.
Goodbye.